This is a very interesting question. When do you switch therapies with an EGFR inhibitor? My feeling is you want to maximize your frontline EGFR inhibitor as long as possible. Of course, when you switch would depend on the patient's symptoms and the options you have next. So if this is a patient who's beginning to progress, but it's slow progression, there are a few symptoms, I would do a few things. I probably would try to keep the EGFR inhibitor going as long as possible. Tumors are polyclonal, and of course there could be a resistant population and a sensitive population, and with time, of course, things will, under the selection pressure of a first-line EGFR agent, we will move more towards the resistant population, but I would try to keep the frontline drug going as long as possible. I would at this point, or at some point, when it became convenient, when there's something easy enough to biopsy, probably get a new biopsy and then test it for T790M, which is a secondary mutation in the most common form of resistance. So that would be the first thing. Keep it going as long as possible, gain the knowledge of what the resistance mechanism is. Perhaps the patient has c-Met amplification. That's another treatable, albeit in clinical trial, type of abnormality. Then, of course, if the patient had no T790M, I'd really try to keep the first generation EGFR agent going as long as possible. Because I know if we stop that, there'll be a flare, and we go to chemotherapy, the chance of response will be 20%, maybe 25, 30%, and it won't go that well, even though we can do it. Of course, we could consider immunotherapy at that point. The problem is, at least from some of the big randomized studies, patients with EGFR-mutated disease did not do that well with single-agent immunotherapy, probably because their mutational burden is low, because the tumor was addicted and driven by one mutation, and that makes them less likely to respond. Now, if the patient had T790M, then the light goes off again, because that tells you that here you have a patient for whom you have the next drug. Then the question is, how long can you eke out the benefit of the frontline agent before starting the new drug? But at some point, you do want to make sure that that patient gets the new drug. When also, during this period, if someone is progressing, has to keep an eye on the brain, because sooner or later, the disease will end up there. And of course, there, the morbidity can be much higher. My sense on this patient is the key message is look for EGFR. If you don't look, you won't find it. If you have it, treat for it, even in patients with poor performance status. If they then recur before going to chemotherapy, do everything you can to see if they have T790M, because if they have that secondary mutation, your chance of response would be 60, 70%. And then you have the ability to use a drug called osimertinib, which gets both EGFR mutant receptor as well as the receptor with the T790M secondary mutation, and is much more specific for the mutant than the wild-type receptor, so you have far less rash and diarrhea with this drug. So keep that in mind as a treatment, and then, of course, we need to do more research into how to integrate immunotherapies and some of the other targeted therapies, whether it be c-Met or other targets into this setting.